Hey, this is Pat Iyer with Legal Nurse Podcast, and I have with me today Susan Haibeck, who I've known for several years. She's a legal nurse consultant who has just completed a book on cancer care malpractice, which is directed to attorneys and legal nurse consultants. Susan and I worked together to complete this book. She went through a program that I taught on how to write the book, and then we worked together with me being her editor. So she is just full of the latest information about what can be a dreadful condition and a compelling medical malpractice case. Susan, welcome to the show.
Thank you for having me, Pat.
Let's think about the attorney who contacts a legal nurse consultant and says, I have a breast cancer case, one of the common types of cancer cases. When that nurse is approached by a plaintiff attorney, what are some of the things that the legal nurse consultant should say to the attorney about that request?
Well, first she needs to determine, she can ask the attorney what type of breast cancer case. Was it a failure to diagnose in the pre-diagnostic phase, or was it a misread mammogram, or was it something actually related to treatment itself with the chemotherapy administration, or an error in a medication or radiation therapy? So it depends where on the cancer care continuum the case occurred. And he might not be sure, or he knows there's a problem, but he may not know exactly how to pinpoint it also.
Have you ever run into situations where the attorney came to you with one idea about a case and then you reviewed it and found that it was a different issue?
Yes, I believe I had a case where they thought the physician did not notify the patient about the results of the mammogram simply because he didn't, but in fact it was the report never got to the physician. So there was a little bit of tracking back and all the potential providers that we had to find that type of thing. Where was the gap? Where was the gap in care? Was it from the mammography suite to the primary doctor, or was it the primary doctor to the oncologist? So sometimes you have to pinpoint where the gap in communication was.
Mm-hmm. All right. Yes. I've experienced that as well. Sometimes the patient tells the plaintiff attorney one set of facts, but then the medical record tells a different story.
Definitely.
Now, I'm curious, do you have to be an oncology nurse in order to be able to review this type of case?
No, you do not. You, for the basic, maybe first review, if you're deciding trying to decide if the case has merit, you're basically looking at the four qualifiers for a malpractice case with duty, breach of duty, causation, and damages. So you can determine that if something was a glaring error, but for the fine points, you would want to consult with an expert oncology nurse or oncology physician, depending on the case, because there's so many variables that can play into a smooth development of a cancer care for the patient.
So many steps along the way, Susan.
Yes.
That all have to be done correctly.
And sometimes they're very scattered and fractured due to time delay or location. And I, feel for the patient who has to go from place to place if everything is not in one building to have to figure all this out. And hopefully they have a loved one with them who can listen with them also.
Mm-hmm. When an attorney approaches a legal nurse consultant and says, I've got an abstract of the medical record, you don't need the full thing in order to evaluate this case, what kind of response should the legal nurse consultant give?
An abstract is not the full article. There's going to be information and citations in the full article that's not in the abstract. So we really need to get every piece of relevant information. Now, they may leave out some things that are not pertinent, but the attorneys often don't know what is pertinent to a cancer case. For example, a recent case I was deposed on, for the life of us, we could not find the cancer chemotherapy administration flow sheet. It's like it did not exist. There were some nursing notes, random nursing notes here and there about chemotherapy administered, but there was no flow sheet documenting each cycle of treatment and the response and the labs before. It was all in the physician's progress note, but not the nursing note. We couldn't tell what size needle, Huber needle, was used for a port. We couldn't tell how long they administered the chemotherapy. So I actually went to deposition not having that critical piece of information, and it'll be very interesting to see how that case turns out.
Mm-hmm. Yeah. You know, sometimes there is mysterious disappearance of key pieces in the medical record. Sometimes it's a purely innocent disappearance, but it can profoundly affect a case if the defendant can't substantiate the care that was given because the record's missing.
I don't have too much experience with the concept of spoliation of records, but if it's not there and it's supposed to be there as part of the medical record, I don't know how you can proceed with that. It's totally inappropriate for it not to be there.
Mm-hmm. Mm-hmm. I know when legal nurse consultants think about oncology cases, they probably think typically about the physician in terms of a delay in diagnosis or a misdiagnosis, or maybe a nurse practitioner. What are some of the other healthcare providers who can be pulled into this type of case?
Well, there are numerous healthcare providers, or the fact that a person was not consulted can be a problem also, or did not receive a referral. The radiologist, the mammography technician, we could have, the surgeon, the family doctor, the OB-GYN doctor. Those are the different specialties. And within those specialties, we could have the nurses or the chemotherapy nurse or the radiation technologists, all people involved with administering treatments or evaluating and communicating that information to the oncologist or primary physician. Someone behind the scenes in treatment that I never knew, that I learned long ago, was the radiation physicist. He calculates all the dosages and prints out a beautiful file of the depth and all of the radiation, and people don't realize that all that's being done in the background.
Mm-hmm. Mm-hmm. And one miscalculation can have devastating results.
Exactly. For many people too, if it's a radiation therapy machine that's used every day.
Yes, for sure. And I think you included in your book a story about a hospital that had a radiologist who was miscalculating those doses.
Correct.
Or maybe it was the radiation physicist, or was it an equipment issue? I can't remember.
It was the programming of the equipment. I believe the initial programming of a radiation therapy administration machine was actually programmed with the physicist and the company representative. And 4 years later, a new radiation oncologist came on board and realized it was delivering too high of a dose to every patient.
Oh, after 4 years.
Yes, it was devastating.
Oh, wow.
So maintenance of equipment is an issue nurses don't often think of unless we're in the hospital and calling for something to be fixed. But maintenance of the radiology machines, the mammography machines, any technology, pumps, those all need to be maintained also. So that's in the background of some things that can be looked at as a violation of the standard of care.
Mm-hmm. I know we just talked a few minutes ago about delay in diagnosis or misdiagnosis. What are some of the most common deviations that relate to cancer care cases, specifically related to breast cancer?
Probably not following up on a lump or something visualized, on a physical lump felt, but maybe not visualized on mammogram, or the opposite, where something so small on mammogram and not felt by the woman. Those are one of the major ones. And then there can be a delay in treatment because those weren't followed up with properly.
Mm-hmm. Mm-hmm. I know that attorneys often focus on those delays in treatment, and they're concerned about what was the implication of missing the diagnosis. What kinds of outcomes occur in those situations?
The outcomes that occur in those situations are usually a diagnosis at a later and more serious stage. If the length of time is long enough, and it can be different for each type of cancer, if the delay is long enough, and it usually has to be a matter of months, if that delay is long enough, it may classify the tumor in a worse stage and affect survival in survival would be less, prognosis worse. So ideally, we'd like to find things in early stages. That's the whole idea with early detection and potential prevention. So those are cases that maybe are put off, or say, oh no, don't worry about it, or we'll check in 6 months.
Mm-hmm. Mm-hmm. And, I know from having worked on cases and reading about breast cancer cases specifically, that one of the issues is the very active lymph node system in and around the breast area, with the concern that those tumor cells are traveling through the lymph nodes rapidly and early with micro metastatic lesions. Have you seen that in evaluating cases, that cancer can spread very quickly from breast cancer?
Yeah, excuse me. Yes, that can happen, especially going from a stage 2 to a stage 3 or 4. And how quickly it does that depends on the actual cell type when the pathologist looks at it under a microscope, and relates back to the doubling time of one cell becoming 2 cells becoming 4, and how many days that takes. For example, some lung cancers develop very rapidly because of their doubling time, whereas a breast cancer, an average breast cancer, may take 5 to 7 years to show up on mammogram. Not your aggressive cancers, but there are several aggressive types, and those in younger women. And so then there's also the interval breast cancer cases that can occur between mammograms, and that's why it's the recommendations are the way they are.
Mm-hmm. When my husband was diagnosed with colon cancer in 1995, we had to talk about the doubling time, because he was a stage 1 without lymph node involvement. And he said, well, why do I have to go through chemotherapy? I don't have any lymph nodes that are affected. And he said, why don't I just wait to see if this spreads? So I said, 2 becomes 4, becomes 8. And because he's an engineer and mathematically minded, he said, okay, I get it. And he agreed to go through chemotherapy, and he's fine today.
Wonderful.
So I think sometimes it's so important for the physicians to talk to the patients in terms that they can understand, so that they are willing to go through treatment that's going to result in hair loss and discomfort and side effects and all the things associated with chemotherapy.
Yes. The informed consent is very important.
Yes. Well, let's switch our focus a little bit. We've been talking about breast cancer. I think personally, one of the most poignant set of pictures that I ever encounter are these kids who are being treated for oncology problems. And you know these images, they're burned in your brain, I'm sure, Susan, of the little kids
Yes.
wearing a hospital gown with no hair and trying to maintain their spirits.
Right.
How much of an issue now is it in terms of curing pediatric cancers? Have we gotten over the curve with certain types of cancers where we can say, yes, this is going to be a cure?
That's a great question. I've been in the field long enough that I have seen survival rates go from less than 10% to perhaps in general over 80% now, if to live over 5 years. And that's because of just the wealth and explosion of knowledge and technology and ability to treat these kids who all they want to do is be kids. They're not worried so much, depending on their age and their stage of growth and development. They just want to be kids. So it's you're really treating the whole family, and so much has progressed over the last 30 to 40 years with treatment for children.
What are some of the more curable pediatric cancers?
Acute leukemia, definitely. Wilms tumor, retinoblastoma. Some of those people may not even be familiar with because they're taken care of in childhood, and the patient is just okay afterwards, and it's not an issue anymore when people are cured or just following up on a yearly basis. So it's really good to see the hope and the cure rates that are here today versus the 1970s and 1980s.
Mm-hmm. Before we continue the podcast, please spend a few minutes getting to know one of the guest speakers who will be presenting at our September 23, 24, 25, 2021 Virtual Legal Nurse Consulting Conference. After you have a chance to meet this guest, we'll resume the podcast.
Legal nurses, are you looking for tips on hiring an expert witness? Do you know the important questions to ask? Or are you considering serving in the role as the expert witness? Do you have burning questions that you want answered? If the answer is yes to any of these questions, then please join Patricia Iyer and I for our 4th Legal Nurse Consulting Success Virtual Conference, September 23, 24, 25, 2021, and listen to our expert panelists. One of our panelists is Anne Meyer, and she is president of MedLaw Connection Incorporated, which is an independent legal nurse consulting firm that she started in 2005. Anne has earned the LNCC credential and was past chair of the American Legal Nurse Consultant Certification Board. She has lectured and published on multiple topics and is a senior co-editor of the textbook Legal Nurse Consulting Principles and Practices, 4th edition. Anne, can you offer some sound bites about what your presentation is going to be about?
Absolutely. Thank you, Barbara. I'm really excited to be able to present on this topic. I've been a legal nurse consultant for over 15 years, and I work also as an expert witness myself and work with attorneys to help them locate experts on their cases. So I'm here to talk to nurses that maybe already have an LNC practice and are looking to expand their practice by either locating experts or being an expert themselves, or perhaps somebody that's new, that's just getting into things and trying to decide what might work best for them. we're in a really unique position as nurses in regards to the fact that we have a lot of education and experience that we can provide to the community and be able to teach not only our patients, but also perhaps sometimes at trial or in the litigation process. And so I'm looking forward to talking a little bit about the differences, like I said, between the LNC world and the expert world, what it takes to be an expert witness. If people are not sure if they have the right characteristics or maybe the background for that, we'll talk a little bit about that. We'll also talk about the process of being an expert witness and what that means as far as going to deposition, going to trial, actual review of the records, things like that. And as far as locating experts, we'll talk a little bit about how to find an expert, how to vet an expert, questions to ask your expert, and then making sure that they're the right fit for your attorney. So communication's always a key thing in everything we do as nurses, and that's no different here. So we'll talk a little bit about that as well. So really excited to talk about that and then answer any questions that people might have in regards to getting into that role.
So we definitely want to suggest to these attendees, come prepared with your questions. And I think it's wonderful that you are going to define the rules in more clear sense for the attendees. No matter what level knowledge or experiences that you have, if you're a new person in legal nursing, or even if you're the most experienced, I guarantee that everyone will go away with additional knowledge from your presentation and others for this program. So we appreciate that you're joining us. Please attend this conference with your questions and meet our experts. See the link below, lnc.tips/September 2021 virtual. We look forward to seeing you.
Thank you.
Now you've had a chance to meet one of our esteemed speakers for our September 23, 24, and 25, 2021 Legal Nurse Consulting virtual conference planned by Barbara Levin and I for you. Be sure to get your seat reserved at this link, http://lnc.tips/September 2021 virtual. I'll see you there. I remember when I was at University of Pennsylvania getting my master's degree that some of my classmates worked in Children's Hospital in Philadelphia on the pediatric oncology unit. And I would look at them and think, I think that's one of the toughest aspects of nursing, to work with that population of kids. They were getting bone marrow transplants, they were getting chemotherapy, they were losing their hair. To me personally, that was tough as a nurse to think about all of the, it's not just the medical treatment and the nursing care, but it's all the family dynamics and anxiety and intensity associated with treating a child for cancer.
All the psychosocial aspects come into play. The youngest patient and family I had to treat was a 1-day-old infant, a 1-day-old newborn with acute leukemia. And mom and baby were at home 24 hours after birth with the diagnosis. And I was teaching the mom how to give Neupogen to increase, for the white count and preparing for chemotherapy, or yes, whatever it was back then. I don't remember the exact, but I was teaching her. I'm like, isn't having a baby enough? We have to talk about cancer, and their heads were just spinning.
Yeah.
But my experience with the pediatric oncology staff and patients and family is everyone just wants what's best for the child. And it moves forward from there. And all their needs are pretty much anticipated and taken care of.
Mm-hmm. What a poignant situation.
Yes. And being out there in the community, a hospital oncology nurse may not see that. I saw so much as a home care nurse working with pediatric oncology patients. I learned so much. I had like every Tuesday and Thursday, I was drawing blood on 3 young men who had osteosarcoma. I hadn't seen osteosarcoma before, and now I'm taking care of 3 of them. So it was really very interesting.
Mm-hmm.
And they're living their lives. That's the thing. They're staying away from the hospital. So.
I worked on a case of a teenager who had osteosarcoma and ended up getting her arm amputated because it was located in her arm. She ultimately died as a result of a misordering of chemotherapy by the physician. And she developed the TEN syndrome, the toxic epidural necrolysis. So all of her skin sloughed off, and then she had an overwhelming infection. It was a horrible death. And it was her last of 12 treatments. Her treatment had gone very well up to that point, and then the physician mismanaged the chemo order. The mother, who knew her daughter's schedule, was at the bedside talking to the nurse saying, look, and it was leucovorin and methotrexate that this patient was receiving. And
the rescue,
mother,
yes. Mm-hmm.
Yes. So she knew the regimen down cold, and she knew that there was a mistake in terms of the way that the physician ordered it. And it happened at 4:30 in the morning. And the nurse said, I can't wake up doctor to talk about this right now. We'll just have to wait until doctor comes around the next morning. And by then it was too late.
The schedule of some chemo medicines and their rescues were critical. They're just critical. That 2 hours can make a total difference.
Mm-hmm. Well, on that grim note, let's talk about the challenges. We've got an attorney and a legal nurse consultant who are working on a cancer case. There are certainly factors they have to consider. What are some of the challenges that an attorney has in tackling this type of case?
The challenges are proving the cause and effect, proving the causation, and depending on the damages, where to look for that. Who is there that's available to be the defendant? Can they sue the hospital? Do they sue the doctor, the nurse, the outpatient facility? So they really need their expert oncology witnesses as the expert oncology physicians to help determine that doubling time and help determine if the outcome would have been better before, if it was diagnosed sooner. That's one of the major ones. And then sometimes combing the records and looking at the timeline of how things happened. Is it a complication or expected complication, or is it negligence? Because due to the medication error you mentioned, she might have had some skin reaction no matter what, but it shouldn't have been sloughing off. Her skin should not have been sloughing off, especially after 11 cycles. And she's known to have the medicine before. Mm-hmm. So that's what's really different with that.
One of the things that I heard when I was out in Las Vegas this past weekend at the National Speakers Association, in a different context, I was talking to a Secret Service agent who had quite a bit of experience in healthcare fraud. And he talked about how difficult it is for the government to pursue extremely complicated fraud cases, particularly Ponzi schemes and similar types of schemes. Have you experienced, as a legal nurse consultant, cases where they were so complex that the plaintiff attorney decided not to take them?
Oh, that's a good question. The only time I've seen that happen is when it's perhaps, like you said, not so complicated, but so difficult to get the point across of what went wrong, hard to prove. There wasn't, you couldn't do the true proof. It was hidden too well. There was enough reason to not move forward. Or if the plaintiff has a unreliable history for some reason and was not able to cooperate.
Mm-hmm.
Now, there are some huge completed lawsuits that have involved fraud. There's a particular physician in Michigan who there were over 450 fraud cases against him. He was treating people without cancer. He was prolonging people's lives when he shouldn't have. They did not have, some had less extensive cancer than they were told, and he's currently, serving life sentences in jail. And those were approached as fraud cases, not as malpractice cases.
Mm-hmm.
So the civil suits will be there also.
Mm-hmm.
Very sad.
Yes. That's a horrible story, Susan.
Thank you. It is. I was nauseated when I first read about it. I thought, how can this happen when the physicians I've known have been dedicated and respected and only, wanted the best for the patient and the most recent treatment. And of this was in Time magazine. So that, he basically owned all the treatment centers and radiation centers and was the only doctor. So, and someone else discovered in reading his previous notes, that there was some problems and there were some shady practices in the office of
Mm-hmm.
using more supplies than usual.
Mm-hmm. The kind of thing that legal nurse consultants are skilled at being involved in, the painstaking, detail-oriented work that we are so good at.
Exactly. And seeing what doesn't match, or knowing what should be in the chart and what's not in the chart.
Mm-hmm.
Oh, look, they didn't chart this, or it's charted 3 times. Why is that? Or, missing records like we talked about before briefly.
Mm-hmm. We've covered a lot of territory, Susan, and I know that people who are watching this on our YouTube channel or listening on our audio channels, including podcast.legalnursebusiness.com, are going to want to connect with you. What would be the best way for them to be able to reach you?
The best way is through, they can email me at Susan at HaibeckandAssociates.com, and or my website at HaibeckandAssociates.com. That would be
Great.
fine.
Well, thank you, Susan. You have shared some insight. I think you've also given us some hope when you've talked about the pediatric cancer cure rates, which I did not know were as high as you revealed. And I think that's important for us to keep in mind. Particularly if a child's tumor is diagnosed in time, that child does have a very good chance of surviving that diagnosis.
Definitely. And fortunately, they are rare, but when we do see them, they're terrible. So.
Mm-hmm. So thank you for being an interview subject on the show. And thanks to you who has been watching the show or listening to it. Be sure to come back next week for a new show about legal nurse consulting and the ways that we can assist attorneys. And if you would like to receive the transcripts of this show, click on the show notes on podcast.legalnursebusiness.com for the ability to access transcripts and to be able to read or refer back to the material that Susan shared. Thanks so much.
Thank you.
This is Pat Iyer with Legal Nurse Podcast. Joan Earley is with me today. She's a neonatal expert witness and life care planner who focuses on pediatric life care plans. Joan, what were some of the key things that we covered in your podcast?
Pat, we talked about the importance of communication between the nurse, the provider, and parents in the NICU. We also talked about liability issues in the NICU, as well as the importance of preserving the skin of preemies and babies in the NICU. Some injuries also that they can incur as a result of being in the NICU.
Be sure to catch Joan Earley's podcast as we talk about neonatal liability issues, some of our most smallest and most fragile patients, and injuries to them can give rise to lawsuits. Thank you so much. Be sure to get Legal Nurse Podcast and Joan Earley's episode.